Yes, I have just a couple of slides to get us started just because it's the first webinar. And then we'll go ahead with our presenter. Okay, so let's go ahead and get started. So I just want to welcome everyone on behalf of the National MS Society. It's great to see everyone here as we start a new year of the Clinical Fellows Difficult Case webinar. The webinars will run from today once a month through May. So I look forward to seeing all of you over the course of the next few months. To get us started, I just wanted to go over a couple of housekeeping items, and then I'll hand it over to Jennifer Graves and Scott Newsom, who are our co-facilitators for the webinar and who will be the facilitators throughout the year. So to start us off, I just wanted to go ahead and talk a little bit about our diversity, equity, and inclusion statement. So this statement is something that as the National MS Society, we have developed to utilize both internally and externally. So I'm just going to go ahead and read that here. The National MS Society is a movement by and for all people affected by MS. Our voices and actions reflect diversity, equity, and inclusion. We welcome and value diverse perspectives. We actively seek out and embrace differences. We want everyone to feel respected and to be empowered to bring their whole selves to ensure we make the best decisions to achieve our mission. This is a space where your voices will be valued, and we encourage the fellows here to bring your diverse perspectives forward in these conversations throughout the year. So, did my screen just stop sharing?
Yes, it did.
Okay, so we made it a whole 3 minutes without something going wrong. Yeah. Just a second. Oh, Victoria, did you share your screen? All right, let me go ahead and share mine again.
Sorry.
That's okay. Okay, so we will have one presenter tonight. We did have one person who was unable to make it, so typically we will have 2 people presenting. We will have breaks throughout the presentation for feedback. We do ask that the fellows come up first to provide their feedback, followed by faculty. We encourage everyone to utilize the raise hand feature throughout. And that makes it easier for Scott and Jen to kind of know who wants to speak and to be able to call on everyone. So all the presentation slots are currently full. If you do want to speak, you can email me and I will put you on the wait list. We inevitably have individuals who have to back out for one reason or another. So I will keep a wait list throughout the year and let you know if a spot comes open. So the meeting link is the same each month. I know this question comes up a lot. I send out a recurring meeting invite. Sometimes it doesn't show up on your end for some reason as a recurring meeting invite, but just know that this link is the same every month. And the webinar will be the second Tuesday of the month each month. Our co-facilitators again are Dr. Jennifer Graves and Dr. Scott Newsom. And I just encourage everyone to stay on until the very end of the call because we have an exciting announcement to make. So with that, I'm going to go ahead and hand it over to Jen and Scott.
Go ahead, Scott. Thank you, Hope. That was fantastic. Now we have very little that we have to say. So we just reiterate how excited we are to hear these case presentations and to be able to help facilitate what are often just fantastic discussions amongst faculty and our new and up and coming fellows. We are going to try for each case to stick to around 40 minutes each, just to make sure every month we have time and we can give equal time to both presenters when we have 2 presenters. And we do encourage those presenting to do about 15 to 20 slides, so we have lots of time for discussion in addition to review of slides during the case presentations. And as Hope said, if you have specified places in your presentation where you want to stop and have discussion, that can be helpful too.
Yeah, absolutely. I just want to echo a couple points. So we really are excited for a new year, and we know the fellows who are attending are going to do a bang-up job with these presentations. And if you do just as good a job as last year, we're really excited. And Victoria has a little bit longer of a presentation this time because there's only one presenter, so I'll throw that out there. And just to echo what Hope had mentioned, we really want to have dynamic discussion. And, this webinar is for the fellows, right? So we really want you as fellows to be involved in the discussion, and hence why we are going to have the fellows talk first when there are questions brought up, and then the faculty will throw in their sort of 2 cents or maybe 3 cents if you have it, and we'll start with that. Okay. And Victoria, if you have spots in your presentation where you feel like, oh, this will be a really natural spot to ask questions, please shout it out and ask the fellows, whether it's differential diagnosis or additional testing that, should be done at a particular point in the case.
Scott and Jen, could I just have you guys make some comment about everybody who speaks to tell us their name and what institution they're from? Because this is something, as you know, that we're tracking for participation. We're not taking attendance, but this will be more clarified at the end. But I think that's an important aspect of this.
No, thank you, Elliot. That's perfect. And I would say also faculty mention who you are and where you're from. Very, very good point. And what Hope sort of alluded to at the very end, so Dr. Froman and the Fromans, I should say, are going to talk a little bit about awards that will be given at the end of this year. And very exciting. This is something new. This is going to elevate, I think, this year's webinars. And so we're very excited to hear from Dr. Froman and hopefully the Fromans as a joint. Okay. So Victoria, with that being said, why don't you start your case?
All right, so my name's Victoria. Can everyone see my screen?
Yes, looks good.
Perfect.
Awesome.
How do you pronounce your last name? Levasseur?
That's probably the right way, but I say Levasseur.
Levasseur. Okay. All right. Thank you.
It's American way to present it, but I think the way you said it probably.
It's hi. This is Rana. It's Levasseur.
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 I stand corrected.
Perfect. Right, so I just started my second year of MS Neuroimmunology Fellowship at WashU. I think last year John Ciavi presented a case. So my case is a little bit less straightforward as far as in the end, but I thought it would be interesting and good for discussion. So it's a case of acute meningoencephalomyelitis, unknown etiology.
You're muted.
You're muted. Yeah.
I don't know how that happened. Sorry about that. So I'll just start from the beginning then. So this is a 20-year-old Black man with a history of migraine without aura, and he presented to the ICU from an outside facility. He was having a couple days of persistent bitemporal headache with associated fever, although we don't know if he had a true temperature, nausea, and sensitivity to light. Some history before that we had gathered is that he was previously pledging for a fraternity and may have been sleep deprived. 2 days prior to admission, he was involved in a motor vehicle accident versus a deer, but he did not have any injuries and no head trauma that we learned about. So on initial evaluation at an outside facility, he was completely awake, oriented, had no nuchal rigidity or infectious signs, and was not in any distress. And then as he was admitted due to concern that he could have, some kind of meningitis, and so 4 days into hospitalization, he began hallucinating for his mother, had one episode of unresponsiveness concerning for a seizure, and became more agitated. So ultimately, he was intubated for airway protection concerns that he was becoming more lethargic, and then.
Do we know how heavily he was drinking at the pledge parties?
So according to when we later asked the patient, he was not drinking heavily or using any substances at the time. It was a late activity.
Okay, thanks.
There's just real quick, Victoria, there was a question about what hallucination means. Like, was there any description from the mother? And then also the sensitivity to light.
Sure. So for the hallucinations, what I was told is that he was.
Hey, I said no, didn't I?
Using like the remote with something else, so confusing objects, more of maybe an illusion. And then at one point, I think he was seeing people in the room, like his friends, as he was progressing. And then photophobia, I don't know the nature of it, other than that he was reportedly sensitive to light, but I don't have too much detail on additional features. So I'll start a little bit background. So, additional medical history other than migraine. He had some joint hypermobility he was tested for. So that,
Victoria, you're going
I'm
in
going
and
to
out a little
introduce
bit.
you. Yeah, or I'm going to interrupt you just a little bit. I think there's some background noise too. If people can mute, unless you're speaking, I think that might be interrupting too.
Yeah, I hear a little bit of that, but it went away.
I don't mean to beat a dead horse, but Victoria, one question about the hallucinosis. You mentioned seeing his friends. Was there a sense that his friends were actually present, but then they left, but he felt he could still see them, like palinopsia? Or was this truly they weren't present, had not been present, but he thought he saw them?
I think it was the latter.
Okay, I'll mute.
It looks like while we're paused, it looks like Nuriel might have a question. I see one hand raised. Did you want to ask your question now?
Yeah, if you don't mind, and sorry, Victoria, to perseverate on this. Like the nature of the outside hospital, sometimes we don't quite know. But I was actually curious. He presents with like a headache and maybe some subjective fevers, but he's there for 4 days before he hallucinates, which feels like a lot of time. Like, what was happening then? Why were they so suspicious still?
So, and I'll get a little bit towards the workup that they did.
Got
so
it.
had
Thank
some
you.
findings that they were worried about, and they were doing some additional testing, kind of waiting on results. And then over that period of time, he started to get a little bit worse. So as far as his history, if you guys have kind of had a chance to take a look through, he played football, so he had a fracture in the past, and then don't think there was really anything beyond a little bit of joint hypermobility in his history. There was not a real concern for anything beyond this. He wasn't on any medications, no allergies, and then lifestyle-wise, he occasionally used marijuana, no IV drug use or tobacco or alcohol use, and then he was playing football in college, but had just gotten started on that, and no family history of neurologic or other issues. Okay, so what we were able to gain from the outside hospital, he initially had a sodium that was 122. He was tested for COVID, that was negative. His initial LP was done after he was started on empiric antibiotics, but it did show that he had elevated white blood cell to 17 with a neutrophil predominance, no red blood cells, protein of 77, and a glucose of 59. His bacterial and fungal cultures were negative, and then you can kind of see all of the viral and microbial studies that were done, which were unremarkable. So, any questions with these lab results?
I guess maybe we could have one or two fellows comment on maybe the spinal fluid results. Does anything catch your attention, especially like the differential?
Did he have imaging first? I would assume.
Yeah, I'm saving that for a little bit later.
Dr. Balser, always one step ahead.
I'm not a fellow anymore, but sorry. Sorry.
Yeah, I guess if Thomas, you have your hand raised.
I see that the patient's glucose is within fairly normal ranges at about 2/3 of the total what would assume to be normal glucose. We can see that the protein is ever so slightly elevated. There's no red blood cells, so but the white blood cell count is a bit high. The neutrophil predominance. I think that this testing was appropriate for this particular case, but it appears all of the nice, easy smoking cunts are negative.
Yes.
And so the neutrophil, when you see neutrophils in the spinal fluid, it always catches my attention for infectious etiologies. But we do know sometimes that the lumbar punctures, it's a matter of timing when you actually do the lumbar puncture. And so we know in immune-related conditions, you can sometimes see neutrophilia as well. A couple other hands, we have Amy, you, and Lindsay Ross. And
hi, I'm Amy. Yep. I'm a PGY new first year MS fellow at Columbia. Nice to meet everyone. I think the interesting thing is that protein strikes me as quite high for someone his age, and it just makes me similar kind of along what everyone else said, but probably an infectious etiology, not high enough to think about like sarcoid or something like that, but to be considered. So interesting.
Yeah, very good points.
It's Bob Lissack. I don't know if we've finished picking on the fellows yet. So the protein is interesting. Viral infections frequently, if you tap them early enough, will have polys. In fact, polio was the classic. So by the time you tapped them later, they were lymphocyte predominant, but acutely they were heavily poly predominant. The other thing is I don't see EBV by PCR.
Yes, that was not done initially. I don't know if...
Because Alex Ellis and I reported a patient who sounds a lot like this one, was actually a professional football player. He didn't play for the Lions, but anyway. The EBV was done actually at WashU for us. Back in neurology in the mid-'80s, early to mid-'90s. So EBV can do a lot of strange things.
And then before Elliot, I guess you make your comments. Lindsay or Hamza, I see that your hands are up.
Yeah. Hi, this is Lindsay Ross. I'm one of the fellows at Cleveland Clinic at the Mellon Center. I had probably one comment and one question. In regards to this spinal fluid, you mentioned the patient had been already started on antimicrobials prior to this. I was kind of wondering how far in advance was he potentially being treated before the TAP, and then was Listeria looked for with the low sodium?
So at the outside facility, Listeria was not tested for, and this was at least 2 days into empiric treatment.
Thank you.
Great questions.
Hey,
Hamza, I don't. Oh, go ahead.
Yeah, sorry. I'm Hamza. I'm one of the new MS fellows at UPenn. So I was gonna bring up the same sodium issue. Maybe overall from the beginning looks like acute to subacute onset. Some later on there were hallucinations and some encephalopathy, and nothing focal really in the history so far that as we hear, but definitely concerning neutrophilic pleocytosis. Also, the sodium level looks like to me more like a cerebral salt wasting pattern rather than anything else, like I say, ADH or other etiology. I would be more interested at this point into the imaging. Any destructive lesion probably can contribute to this presentation, both pleocytosis as well as cerebral salt wasting. The other thing, initial presentation, even though it was subjective and we have some pleocytosis, even though HSV was negative at this point, I would be still interested in the idea of encephalitis, herpes encephalitis, and I would agree with the Empric, acyclovir, and other antibiotics.
Can I also raise one other point quickly? Don Gilden, the late Don Gilden, used to point out that besides doing PCR for some of these viruses, you should do serum and CSF, IgG, and IgM antibodies against it, because it's sort of like a viremia in the blood or a bacteremia. You can miss it if it's there transiently. Okay, and so Don used to routinely, and he has had this little book called Neuroinfectious Disease, sort of a case presentation system, and he makes the point there. So we routinely, I mean, this was outside hospital, would also have sent for antibodies G&M for the HSV, the VZV, and the CMV, just because Gilden was often right about viral infections.
Okay, well, why don't we have Victoria go through a little more of her slides? This is great. We have a lot of hands up. So maybe some of the questions can be saved for other pause points, and I'm excited to see what Victoria's team had ordered, and obviously looking at the MRI may be somewhat informative as well.
Yes, we are very close to getting to an image. I just wanted to share a little more detail, just 2 more slides of kind of logistics. So he was ultimately transferred to the ICU at our institution and was intubated and sedated. His limited exam showed that, so he was briefly taken off with propofol, and he had a right gaze preference, a weak cough, his pupils were reactive, he localized on the right, and then was diffusely hyperreflexic in his bilateral upper extremities and had seemingly normal reflexes in his knees and ankles. This started on EEG that showed right temporal parietal slowing, and he had more of an infectious and inflammatory workup. MRI, brain with and without an MRI, were performed. So just wanted you guys to all see some additional workup that was performed. Some of the tests that were brought up are still not on board, but we do have more kind of external outside of the CNS testing that was done: hepatitis, HIV, RPR, Rocky Mountain spotted fever, Bartonella, HTLV, serum AIM panel, NMO, and MOG. And then some rheumatologic testing, vitamins, screening, and the AIM panel was also done in the CSF. I have it listed twice, but and then he had a repeat lumbar puncture that was a little bit more concerning. The protein bumped to 427, and he had more red blood cells than previous, so 159. There's a little bit of a shift in the differential as well.
I guess Raina and Elliot, if you want to ask your question real quick, that you've been very good with leaving your hands raised.
Yeah, just very quickly, I think, Bob Lisek had mentioned this issue of early versus late infections and the ability to see polypredominance. I mean, the other issues to think about is that if that were the case and we see a conversion to a more aseptic pattern, then we got to think about not only the virus, but we got to think about bacterial agents that can cause an aseptic pattern. I'm thinking more dynamically. So the 2 that come to mind would be mycoplasma and leptospirosis. But acutely, you can see neutrophils. And then, of course, the other area I wanted to point out outside the infectious realm is the polypredominance or polypresence that we very commonly see, of course, in NMO, NMOSD, particularly during acute presentations with a pleocytosis. So you're thinking about patterns that might associate with, but there are some not red herrings, but there are concerns here with the metabolic and electrolyte derangement. So, but things to keep in mind, and oftentimes people forget about those agents that we treat differently, like mycoplasma, and seen that happen. So 2 bacterial agents that can present with an aseptic pattern, but acutely can have neutrophils: leptospirosis and mycoplasma.
referrals. Dr. Zabat, do you have a comment?
Yeah. Hi, this is Rana Zabat from University of Nebraska Medical Center in Omaha. So just a quick question, if there was any eosinophils on the first CSF study, and then if the guy is known to have consumed any non-steroidal anti-inflammatory agents.
So eosinophils, no, not on the first lumbar puncture. And then I don't know if he did have a headache, so it is a possibility that he had taken some NSAIDs prior to coming in.
All right.
I can't confirm.
Rana, can you just further comment as to why you asked that very important question? It's a great one.
Yeah, the two of them. One of them is the presence of neutrophils and eosinophil argued are the presence of a complement activation. And because of the chemotaxis, you can see neutrophils, eosinophils in the CSF. And then the NSAID, because there is a rare condition associated with aseptic meningitis and neutrophilia due to NSAID.
Okay.
And it's even vasculitis, right?
Excellent points. Esther, did you want to say something? You also had your hand up for a while.
Yes. Yeah, very interesting case. And I agree with Dr. Froman about the question of neuromyelitis optica and neutrophilia. So one question is whether I see that the NMO, IgG, and MOG were negative. Were these done by CBA assay, by cell-based assay, or by ELISA? Because there will be different sensitivity and specificity between these two tests. And then the second question is, your patient is presenting with signs of encephalitis. Was an autoimmune encephalitis panel sent for this patient?
Yes, so the autoimmune encephalitis panel was sent in the serum and the CSF. And then NMO and MOG were both sent off to the Mayo Clinic for testing. So I think that means they should all be cell-based.
Great.
I have a question for the fellows maybe to weigh in on. And what do we think about this second protein of 427? This is quite dramatic. So any of the fellows want to weigh in on how this would impact your differential? Amy, raised your hand, Amy.
This just makes me really kind of like what you, I think one of the faculty I saw earlier, mycoplasma, TB. I had a patient, when you have proteins like so high, then you're really getting to the strange infections, especially without glucose dropping a little bit too. That would be my main concern. But why would this young, healthy man get TB? That's a little strange.
Right, Nuriel and Hamza might have answers too, it looks like. Nuriel, you want to go first and then Hamza?
Yeah. I realized I didn't properly introduce. So Nuriel, I'm from USC. And on top of the differential everyone else is giving, I think as Amy mentioned, we think about TB, high protein. I mean, this isn't in the thousands, but you can think spinal block. This guy had elevated upper extremity reflexes acutely as well. So I want to see what's going on in this guy's neck probably at some point.
Excellent.
Yeah, from my view, I think at this point, given the fact that he is African American and worsening elevated protein and pleocytosis, even though we're thinking of infectious process already, I think I'm more concerned about inflammatory processes, mainly sarcoid in this case. I think that may go higher in my differential when working up this case.
Yeah, Hamza, with those cells, would you want cytology? Make sure we don't have some kind of leptomeningeal carcinomatosis.
Absolutely, I think it's reasonable with this cell count. I don't know if he had any other B symptoms, anything in the history suggestive of any malignancy. In that case, absolutely, I think that's very reasonable cytology, even flow cytometry. And we haven't seen the MRI yet. I'm sure we'll have more clues on MRI. And one other point I want to make, I'm sure it's done, but most of the time during my residence here, it gets forgotten. We know he has history of alcoholism, even though maybe he wasn't drinking a lot. Was this patient given thiamine initially before he developed all those hallucinations and other symptoms, encephalopathy?
No, he was not given thiamine. That's a good point. And then to your question about these symptoms, he wasn't having anything other than what sounds like a subjective fever, so there wasn't a history of weight loss or night sweats at all. So, but there are a few LPs to go. So, some of the testing that was mentioned was definitely pursued. But I will show, so I have a single MRI slice to get us started. So I know it's kind of noisy, but I guess we could start by somebody describing what they see, but basically there isn't, any obvious lesion. But would everyone agree that he has some diffuse flare non-suppression or lack of CSF suppression on this flare sequence?
Yeah, it's a rough MRI. It's I would say if we gave this to one of our neuroradiologists, they would not commit one way or the other.
Yeah.
Yeah, but I'll raise my hand.
And I know Raina and Bob are waiting to comment too. I'm trying to track everybody's hands. So maybe Elliot, Raina, and Bob, maybe we can let you guys talk after we've seen this MRI now.
Yeah. If I could just briefly make a comment, just by it's not this motion artifact. It's not great, but I get this flavor of this kind of this Christmas tree bright cortical laminar brightness that, of course, we can see in patients who have cortical laminar necrosis from either hypotension, hypoglycemia, prolonged seizure, and obviously predisposing to other places like thalamus and pons. But and I could be wrong, it could be the quality of the study, but especially in the frontal regions, you get the sense that there's cortical laminar brightness like you might see in those circumstances. So I don't know if that's true or not, but that's my first impression.
Absolutely. Raina?
My question is, so far, 2 CSF studies and no immunoelectrophoresis yet. And
Right. So you're talking about
yeah, the IgG index synthesis, oleoclonal bands, and blood sebum protein electrophoresis.
Right.
Not yet?
Not yet.
Okay.
It will be shown.
Okay.
So
I would consider this MRI abnormal, though. The cortex is too hyperintense.
Yeah.
And certainly, if you have the one with contrast, it might give you a better idea.
Yeah.
I mean, I think that's an abnormal cortex. I agree with Elliot and Raina. Remember that if your radiologist read it, they always hedge. That's the plant that represents the Radiology Society, the hedge. The other point, Elliot was right about even though it's a young kid without any known cancer. Jerry Posner pointed out, when you see proteins in that level, you really have to look a few times. It's very impressive level.
And lots of cells to flow, so make sure that you do flow.
Right. Okay, so I'll show you another sequence. I think you guys can see where this is located. So further down on this image, there was a subtle hyperintensity in the splenium, and our radiologists were noticing that there was some diffusion restriction. He also had an MRA that was sewn along with this study, and that was unremarkable. So anyone have any thoughts about this type of lesion? It was given a name that sort of led us in a direction, but we're not really sure if it was useful in the end.
Yeah, let's have the fellows chime in first. It's like Hamza has his hand raised.
I think these lesions called clock, the cytotoxic something of corpus callosum, but mostly associated with toxic metabolic though, rather than any vascular or inflammatory processes. Maybe sometimes with seizures, but I think mostly toxic metabolic.
Right. That's exactly correct.
Hamza, we love
Yes,
you.
sir.
We love you. Keep going.
Thank you.
Yeah, we do.
Nice work. So I'll kind of leave us there if that's okay, and then I'll try to move forward. Ooh, sorry. Okay. So, and then this next sequence was contrast enhancement, showed a little bit of radial periventricular enhancement. And so I'll let anyone make comments on this or kind of add a little bit to their thoughts if this brings anything up.
Sure, do
fellows.
you have a coronal or a sagittal? It usually is more striking on that, actually.
I'm having a hard time seeing it. Yeah.
I can see it now that you've pointed it out, but if you look at the original papers from the Mayo, and I wrote the original editorial, the sagittal is like blows your mind away.
I don't have any on these slides.
All right, thanks. That's okay. Don't worry about it.
So Hamza has. Let's start with Amy, and then we'll go to Hamza. What are you thinking?
The radial vasculature, the enhancement, with his CSF profile, the atypical lymphocytes, really strange, like intravascular lymphoma, where this is a neuroimmunology talk, so I don't know if this is going that direction, but there's so much overlap between, the oncologic and the inflammatory. So this is something also to think about or to rule out.
Oh, so what you'll come to learn as a neuroimmunologist, you have to keep all of this in your differential, because in your career you will see everything that's mentioned, and so you have to be open to thinking about intravascular lymphoma, tuberculosis, meningitis, listeria, meningoencephalitis, and they may come to you for rule out MS. And so it's amazing to me the number of people that I've seen over my short time frame that has not been MS, but they were sent to me for MS. So it's really, if you don't think about it, you're going to miss it. Mm-hmm. Hamza, you have your?
Yeah, I think it's a little hard to interpret on this one cut image. I don't know, these bilateral temporal lobe, are they vessels or real leptomeningeal enhancement? Maybe there's a component of pachymeningeal enhancement too. But the one thing, maybe very, very subtle, the reason I noticed we had a somewhat similar case, we discussed a similar case recently around, I think in the basal ganglia, there is some, I think it's a real enhancement there, maybe radial and longitudinally and perpendicularly oriented to the ventricle. And I think it's pathognomonic for one condition.
You can say it. What do you think?
Yeah, you're allowed to say it. I mean, it's okay. We don't know what the answer is, so it could be a lot of things. And I'll just mention that with rare conditions, the findings radiologically, you may see this in other conditions that are more common. It's just we're looking for these pathognomonic clinical findings, radiological findings, biomarkers, whatever it is. But you go ahead, shout it out.
Again, we had somewhat similar case, and it turned out to be GFAP astropathy. I think it could be.
Yeah, no, I think that's a great thought in that pattern that I think was mentioned. Sort of this radial, enhancement pattern is somewhat unique. But again, I think we'll probably find out that there are other conditions where you'll see this, but maybe this will be more common in this condition. Okay, we have Esther, I think, wants to make a comment.
Yeah, I agree with the differential that has been already shared. And then one other one to keep in mind for these types of cases is vasculitis, as long as we're thinking about inflammation of blood vessels. So did this patient have a workup to include this on the differential?
So at this point, he had just an MRA, so not gold standard, but he did have at least some vascular imaging that was unremarkable. I didn't put it up here today, but just wanted to mention that.
No, it's a great point, especially with that really high protein, which, you know, we see vasculopathies or vasculitis cause a very high protein. So that's a great point.
It looks
Dr.
like he
Fro?
doesn't have evidence for systemic vasculitis, and for the primary CNS vasculitis, he's a little young, but not impossible. Not impossible.
And Ryan had his hand up, but then took it down. So I wonder, Ryan, were you going to say GFAP? I saw you took your hand down when you.
Yeah, that's right. I was. We were on the same page there.
Okay. All right, Dr. Froman.
Just a quick comment for Hamza, because you raised the suspicion. You know, astrocytes are a large and diverse family of cells that have functional specializations in a number of ways. GFAP is glial fibrillary acidic protein. It's a 10 nanomillimeter intermediate filament, but one of the specializations are the so-called radial glia, which expand from the ventricular ependymal surface all the way out to the surface of the cortex, where those astrocytic radial glia, which is what they're called, terminate in what we call the lamina terminal, which is right on the surface of the pia. And that's how neurons jump on and migrate. So one of the questions is whether this pattern of perpendicular to the ventricle, here we're not talking about like an ovoid or an MS lesion, but actually the astrocytic process, are we seeing in a way the reminiscence of those radial glia? And is there something about GFAP associated meningoencephalitis that affects certain astrocyte family members versus others? That's my only comment about that. But they span from the ventricle all the way till the glial limitans, which is the terminus of that astrocytic process, as the neurons make the cortex. Yep.
I'm not sure if Victoria is going to go over this with the GFAP syndrome, but actually, if you look at the original paper, a lot of the patients had this, and a lot of them had optic nerve disease in JAMA Neurology. When you look at their follow-up page with a larger number, it started to get a little more heterogeneous. And the other thing that's interesting is apparently a dog, spontaneous dog meningoencephalitis like this. But it turns out it depends on which isotype, or isoform, sorry, isoform of GFAP the antibodies are aimed at. But then again, the antibodies are probably not pathogenic because it's an intracellular. And there's an argument that, at least in the dog, that the CD8 T cells, just like with anti-HU, where the antibody is the marker but not the pathogenic mechanism.
Interesting. Raina?
You know, for those of you who have seen a GFAP MRI of the brain, I've seen it only in books. I'm not sure that this was really, did it really look pathognomonic for GFAP? Because what I have seen is more what Elliot talked about, you know, these, enhancement that is radial, starts from the ventricle and extends in a centrifugal way.
Right.
It's usually not a vascular pattern. And again, if you look at the articles, they show usually coronals or sagittals for a good reason, because those are easier to read.
Mm-hmm. Agreed.
Okay, so Victoria, why don't you take us through the next set of data collection that you guys did?
So,
excellent job, Victoria.
Thanks. So
you've got us all going.
I'm glad. I wish you guys were with me when he was admitted. So hospital course wise, I wanted to pause because he started to get a little bit worse, so we had to move a little bit more on intervention. So his exam, just 24 hours later, he was not having any strength in his lower extremities. He was still anti-gravity in his uppers, but his reflexes were diminished in his uppers, and the same with lowers. I know it's not the greatest exam ever, but we were just kind of noticing that he was having signs of decreased reflex. So thought was, we don't really know what exactly we're treating, but we'll start high dose steroids to see if we can help this person, stop decompensating. This is a little bit of a side note. He did develop, he had some issues with his lungs, so he had right lower lobe pneumonia. There was hydropneumothorax. He had bilateral chest tubes ultimately during part of his admission. And then he was fevers and autonomic instability that developed. And then his exam continued to get worse. So this is about when neuroimmunology was involved. So we have a little bit more of an exam where you can see he doesn't have really much strength throughout, except a little bit in his left uppers. So at this point, the thought was, let's do as much as we can. So a Plex catheter was placed, and then finally had some imaging of his spinal cord. So initially, this didn't happen right away because of his patient stability. And I'll show you what I have as far as spinal cord imaging, unless we have any questions or comments.
So Victoria, can you comment on sort of this constellation of findings that you have here, where it's basically quadriplegia, autonomic instability? So what should we think of when you come across a patient like this in terms of localization? And obviously it's a very sick guy.
Sure. So, I mean, we're thinking that things are more diffuse happening in probably spinal cord as well, something that's quickly progressive and with
the drop reflexes. So spinal cord shock is what you have to think about, which is incredibly dangerous and deadly. And so I would say for the fellows, just because you don't see hyperreflexia and you see hyporeflexia, don't think it's not coming from the central nervous system and specifically the spinal cord. So, and I think we have Amy. Amy, you have a question or a comment?
Yeah, just a quick question. The tone, was he like flaccid or I was curious.
Yeah, so his tone was definitely decreased. He didn't have any spasticity.
I feel like then you have to go, given this exam, then along with the spinal shock, but flaccid myelitis or flaccid myeloencephalitis, then you get the weird arboviruses, you get your Powassan's, you get your, it could fit, especially if it's really truly flaccid now.
Right.
No, that's a great point. And actually, I was going to comment earlier, getting a history of where did someone travel recently is extremely important in these cases, because just because someone, let's say I'm in Baltimore, maybe the person's not doing drugs or doesn't have HIV, but maybe they traveled outside the United States and went to some weird exotic area, and now they come back with some bug that's causing their encephalomyelitis. So I think travel history is incredibly important to ascertain if you can. So great points. And then Dr. Froman, you have your hand up.
I have a quick question. Yeah, for Victoria, there was a comment made earlier about this patient's right gaze preference, and I would like to know whether there was a further progression or deterioration of ocular dysmotility. You're describing now somebody with diminished reflexes and weakness, and there are a lot of unusual features to this case, but one of the differentials we would want to think about if we went back and said, gee, now we look like we're moving toward what looks like complete ophthalmoplegia, then, you're thinking about therapeutics, things I can remove. So, Miller-Fisher variant would come to mind with an anti-GQ1B antibody. There's a lot of unusual features to this case, but you did mention that. So the question was, what was the localization, the reason for that right gaze preference, and what happened to ocular motility going forward?
So the reason,
and I think you're pointing out Bickerstaff encephalitis as well, right? Is that what you're? Yep.
Miller-Fisher, Bickerstaff's, that whole region. Yep.
Well, later on, he was able to move his eyes. He had normal ocular motility, so don't have awesome explanation for what was going on initially. We weren't able to detect any seizure activity, and so maybe that's what was happening initially, but it's hard. We weren't able to nail that down, unfortunately.
Hey, Victoria. Let's see what happened next here.
So let me show you some of his port imaging. And then there are several slides. So these are sagittal, but I do have some axial views as well. So you can see his cervical spine. This is thoracic, and able to tell there's some central cord signal abnormality. I know these are not the best quality ever, but that's kind of the general idea here, is that there was cord signal change, presumably from C3 to the conus.
The left one is the stir sequence, right, which tends to be very grainy, but tends to have greatest conspiguity as well. So it's a trade-off, but that's one of the problems with stir. But it doesn't look normal. Yep. Oh, I think your microphone is muted.
Having a hard time hearing you again.
Yeah, there was a loud sound that came through. Sounded like a train going by, but I'm definitely inside. Can you guys hear me now?
Yeah.
Yep.
All right, so this is still the cervical spine, but you can see here that it looks like there may be some diffuse patchy hyperintensity around the gray matter into the white matter. And we have maybe associated with some digital enhancement.
There goes your mic again.
It sounds like you're in a wind tunnel. Like there's like this sound through when your voice disappears.
It's probably coming from the fan in the computer.
Yeah, maybe.
Yeah, I'm nowhere. I'm very insulated right now, so I don't know what's going on.
Victoria, do you have headphones nearby with a mic on it? That might help.
I've never used headphones with this computer. That might throw us off even more.
Okay.
We'll bear with you. We'll just let you know. It's okay.
All right. So that is all for spinal cord imaging that I have so far. So it's kind of diffuse cord signal change, a little bit of patchy hyperintensity centrally, and then some associated leptomeningeal enhancement.
So longitudinally extensive, right? Just want to throw that out there as a term.
Yes. And then I did notice that I think Steve Galetta, Raina, and maybe Hamza had their hands up in the last few minutes. If there was something you guys wanted to say before we moved on.
Yeah, I just wanted to comment that I think the right gaze preference was due to the right tempoparietal dysfunction. It usually is a parietal localization for a gaze preference. So I think that was consistent with the EEG slowing that you saw in that area.
Great point. Raina, Hamza, and then I think Lindsay had a question.
Before these MRIs, I was thinking the change in the exam. I was wondering did it happen after steroid? Was it acute or subacute? I was thinking, are we dealing with an overlapping issue, but something like vascular? But based on these images, probably not.
So, kind of to answer your question, he was started on high-dose steroids as he was getting worse, which is why then flex catheter was placed. So it was pretty acute as far as worsening goes.
Raina?
Yeah, I had a question regarding a technique that I don't know why we don't use it a lot. It's the proton density in the spinal cord, which actually eliminates all the noise that you can find on the stir and gives you a very nice view of the spinal cord. Now, granted that after coming back and practicing in the United States, I have not seen nice proton density done on a Philips machine. But if you have a machine which is Siemens and you have a good physicist, you can have beautiful proton density MRI of the spinal cord that eliminate all the noise. So typically what you see on a proton density is your CSF is gray, your spinal cord is gray, and your lesion look white, rather than seeing a lot of noise. That's number one. Number two, I'm not convinced that the cervical spine is showing abnormality inside the medulla, inside the marrow. There is probably some leptomeningeal enhancement, but I'm not certain about the abnormality unless what I'm seeing here, this hypointensity, that's what's considered abnormal. But the thoracic was convincing. The cervical is not convincing that there is something inside the spinal cord itself.
Great. Go ahead, Victoria.
Okay. So I may move a little bit faster. That's a little bit more data to share, but he had another lumbar puncture, and this is where we have the MS profile. So he had elevated index and then 2 bands. Sorry, I think, yeah, and then the IgG synthesis rate was also elevated.
That term should be banned.
What's that?
The term MS profile or MS panel should be stricken from the books and banned.
I agree. I agree.
Good point.
Note taken. Okay, and then flow cytology part 1 was negative. And then CSF was sent out for PCR detection of anything. So we sent this out, it was to Seattle, and additional studies that were done for different microbes did return negative. That's as much detail as I probably share in this slide about that. He didn't really improve after 5 sessions of Plex, so we decided for 2 more. And then he had a repeat imaging, and I will show you flare. So, and he had some areas, so this is flare and then a fusion. So there were some new areas of flare change, and then he still had this clock lesion that was present, and some abnormalities in the thalamus and internal capsule as well that showed up. And then in the spinal cord, you can see that there was not a lot of improvement in the signal change, and then his paraspinal enhancement seemed to improve. He had additional diagnostic studies, CT chest, abdomen, pelvis, PET CT, ultrasound. Did have an EMG study, and this is a lot of words, but ultimately it was thought that the etiology for his symptoms was not related to his peripheral nerves. He did have a formal ophthalmology evaluation, had a normal dilated exam. Then another LP was performed. Flow cyto was negative, and this is not ideal because it was after Plex. He did require, so he had a tracheostomy placed, and he required more time in the hospital for respiratory reasons. So he ended up getting another EMG that was normal. Enough time, he spent enough time there to have that done, and then we did another MRI, brain and whole spine, which I'll show in a couple slides. So over time, he slowly improved. This is his exam. Nearing admission, or sorry, discharge. You can see that his strength slowly came back. No cranial nerve issues. He had some sensory deficits, so he had diminished sensation to light touch and pin up to and temperature up to his knees, and decreased vibratory sensation in his lower extremities.
And Victoria, can you comment on this exam in relation to the last round of Plex or the last treatment?
As far as improvement, or how far away?
Yeah, how far away from the last Plex?
I would say this was in the weeks range.
I just asked that because I think sometimes the impression is that Plex is going to improve people overnight, and there can be a delayed treatment effect with Plex and even steroids. Whether you commit someone to a stronger immunosuppression during the course of the hospitalization, that's a different topic of discussion. But okay, thank you.
Yeah, so it was definitely not overnight, several weeks. Okay, and then MRI again. Maybe I'm overkill on the MRIs, but you could still see clock lesion here. it's kind of slowly fading out. And then, let's see. And I'm sorry I don't have, the live image. So there was no definite signal change in the cervical cord or any clear leptomeningeal enhancement. And then there was still a little bit of change in the thoracic cord. So I think maybe it's possible that this was the only change that existed prior, but it's hard to tell. Any thoughts, questions?
It looks like Lindsay has her hand raised.
Oh, yeah. Hey, this is Lindsay Ross from Cleveland Clinic. Again, I had a question. Here you guys had sent NMO and MOG, and I might have just missed it, but I wondered if you had sent like the myelopathy autoimmune panel or the autoimmune encephalitis panel. Particularly, I was wondering about CRIMP5, although you guys did a pretty thorough malignancy screen with his headaches, the meningeal component, the encephalitis, and the maybe longitudinally extensive myelitis that came to mind. Yeah,
so we did send the autoimmune encephalitis panel and the serum and CSF. That was done on his first LP, and it included CRIMP5, so it was negative.
Dr. Zabad? Oh, I think you're muted.
You're mute.
I missed if early on you talked about HTLV1 or HTLV2.
Yes, those were sent and were negative.
Thank you.
Well, a quick question, Victoria. Did you guys repeat the PCR for the COVID?
So he had it done at the outside hospital, right, and again when he came here.
Okay, so he had it negative twice. Great, thanks.
And how about the vaccine? Was he vaccinated?
No, he was not vaccinated.
Why don't you
I have a question about the diagnostics here for 1 second. Sometimes there are pediatric disorders which can present in adults, and in the context of this behavioral change, meningoencephalitis, were organic and amino acids sent in this patient. There have been examples of hyperglycemia and other metabolic disturbances, which could explain some of these lesions, for example, like the splenial lesion that Hamza brought up, and I think rightly so. But were any of those assessments evaluated?
They were not. That's a really good point.
And question, Dr. Froman, for you is, would you expect such a dramatic pleocytosis and high protein in those conditions?
No.
Amy? Yes. I just think it's interesting. I think once I'm just like thinking about his timeline, his first LP, the protein was in the 70s, then it jumped up in the 400s, then he got steroids, and by LP 2, 3, and I think 4, it pretty much normalized pretty quickly. So I'm kind of shocked. If I got the timeline right, that was before the Plex. So I think. So whatever he had, it's very steroid responsive, because even before the Plex, I think from a systems perspective, he wasn't well yet, but it sounds like his CSF responded dramatically. So, so just thinking out loud.
Yeah.
No, that's a great point of observation, because we know there are certain disorders that are extremely sensitive to steroids and end up being steroid dependent disorders, where you end up having to commit them to steroid sparing agents, to name a couple: granulomatous disease, which I think, Amy, you had mentioned early on, neurosarcoid, whether it's MOGAD, NMOSD, usually not, right? They're sort of steroid refractory. So it's really, really great observation. Norail?
Yeah, I think along those lines too, Amy, I think I was struck by the protein improving. I think the exam too was a lot better than I thought it would end up being in him. The one question I asked, unless Victoria, you're going to tell us you know what this is, and you're going to give us the answer on the next slide, but this is weird enough too that it's worth invoking whether this is two things. And I do wonder, could he have presented originally with something infectious, and did that trigger something immune mediated that was steroid responsive? And so are we sort of seeing, maybe he had a run-of-the-mill enteroviral meningoencephalitis, which I think gives you neutrophilic predominance anyway. Did that trigger MOG in him or something? I mean, is that a possibility? It doesn't explain the clock lesion, which I think is more sensitive, but or more specific. But just want to sort of raise that as a possibility, and then hear all the reasons why it's not that.
No, I think that's a real possibility for this case. So yeah, I'll explain that a little bit, because and I also think the clock lesion itself isn't specific enough to really be. It could be just a complication or kind of evidence that he's had some toxic metabolic derangement. So your point is very, very valid. So I just wanted to briefly, this slide is just to show that he continued to improve after he left the hospital. He had a little bit of cognitive change, some decreased fluency of speech, but you can see overall, he's able to do most things. He had a little bit of gait ataxia that went away after his subsequent visit 6 months later, and which I didn't include that exam, but he very much improved, nearly back to baseline. So this is actually where the case pretty much ends. We don't have a great explanation for what happened to this person. So we had thought about maybe getting additional CT chest, abdomen, pelvis, but ultimately decided to follow him with serial imaging. And we're left with a person having longitudinally extensive transverse myelitis with an associated leptomeningeal enhancement and clock lesion. So it could have been a post-viral inflammatory syndrome. We weren't able to identify any autoimmune process with our testing. And underlying malignancy has become less of a concern as more time has passed. So it's unclear, what's going, if anything, will reoccur. That's pretty much the end of the story. And then I do have a few slides about the clock lesion, and then something about GFAP if anyone wants to hear, or if there's a different direction we want to go with slides.
Yeah, Victoria, I think what you just said there is great in terms of early on, you don't really know, even in these dramatic cases, whether this is going to be sort of a one and done monophasic illness, or is this going to go on to develop into a relapsing, remitting condition, whatever it is. And I think this is where it's not so clear, like how long do you follow someone? How often do you do imaging? I think some of the things are pretty straightforward. If someone's deteriorating, of course, you do an MRI, bring them into the hospital probably to expedite it. But it's really unclear, and it'd be great to hear, I think, what our total experience is. Before we go into that, Amy, it looks like you have a hand raised.
Yeah, I still have to bring up the initial CS. I think it was the CSF. The ACE was elevated, and I just can't ignore sarcoid, because it's just so steroid responsive. His protein is so high. The question I have for you is, I know he got all those like pulse steroids in the beginning and all the Plex. Did he continue on any kind of just maintenance steroids at all during all this when he was recovering?
So we sent him home on a steroid taper, but by the time he was seen in follow-up, he was not on any steroids. So we didn't continue any low-dose oral steroids, and he still did fine.
I would make a comment about the ACE level. Carlos Pardo, who's at Johns Hopkins, who's I would argue one of the world experts in neurosarcoid. When I was a fellow and I would hang my hat on ACE levels, he basically said, nope, do not order that ever again. It's like it's worthless to order. It has a very low specificity when it comes to granulomatous disease. And so he sort of beat it out of me. So I never order it. Bob Lissack, I know you've made comments on prior webinars related to ACE.
I don't order it either. I know that in the chapter in the International Neurology that Barney wrote, Barney Stern, he put it in there, and I challenged him. I said, if you're going to do an ACE in the CSF, you better do one in the serum and do an ACE index, because all you may be seeing is leaking from the blood brain or blood nerve or blood meningeal barrier. The other thing is it's made by mononuclear cells. That's why it's up in other granulomatous diseases. So it just tells you what you probably already know in this guy, that he's got something inflammatory.
Mm-hmm. Right. And in cases of neurosarcoid, 50% of those have completely normal ACEs. So if you're going to be thinking about it, you ought to be doing nuclear scans, indium-111, gallium, whatever.
Right. So, I mean,
look at the skin, look everywhere. You got to find something.
I don't know if they're still doing that study, but at one point, Barney and Walter Royal, who's down back in Atlanta, were talking about it, and we were talking about ways to convince the insurance company to let you do a PET CT. I just had somebody order in the residence clinic today the poor man's PET CT, or the poorly insured, which is a gallium scan, which sometimes is positive, although I think Barney's right that the PET CT is probably the penultimate, looking for hidden occult things.
But Amy, I appreciate you going back to sort of the drawing board, because I think that that's what we all need to do with these complicated cases is, okay, what do we know early on? How does this behave over time? What is the paraclinical data that may support one condition over another? And occasionally you have no clue, and you say, okay, well, we ruled out infections, we ruled out as best as we can neoplastic processes, and we come back to the neuroinflammatory bucket. And then it comes down to what Victoria is going to have to sort out. Is this a monophasic illness or relapsing? Do you commit someone to an immunosuppressing drug, a young person, long-term, or do you wait for another devastating attack to occur? So these are really challenging cases.
Hey,
Go ahead.
I just wanted to add one thing. A number of years ago, a young woman was sent to me. I was just shown the films by neurosurgery because their plan was to biopsy or take it out. It was a very impressive lesion in the splenium of the corpus callosum. And I said, well, before you touch it, like you're talking about, before you commit to immunosuppression, young person, here's another example of before you take this out, let me talk to this gal. And her mother was in the room, and I struck up a conversation. I said, look, you can tell me anything and everything, but I need to know just in case it's related. And she came clean. And not only did she come clean about her history of migraine, but she came clean about her abuse of fen-phen to lose weight. And her particular symptom, if Galetta and Laura are still on, that this young girl not only had this splenial lesion, she had this kaleidoscopic illusion of crushed colored glass in her field when she was using fen-phen. When she admitted this to me in front of the mother then chimed in and said, oh my God, your older brother had exactly this same syndrome that you don't know about, who also has a migraine, and this is when he was abusing crystal meth. At which point I begged her to go off the fen-phen and let me just scan 3 months later, no surgery, no biopsy. And I think, Hope, are you still on? Can you pull up that paper that we published on this case years ago? This is a very impressive splenial lesion. And I loved Hamza for bringing this up about, toxic metabolic. This was a completely reversible lesion in the splenium of the corpus callosum. Her brother, crystal meth, and a history of migraine. I think that's probably relevant. They both had this kaleidoscopic visual illusion, and the sister with fen-phen. Hope, are you still there?
Elliot, do you think we could let Victoria finish? She's got a few more slides and then
Sure.
pull yours up. Okay.
Absolutely.
I did just swap to clock lesion slide because maybe this kind of segues into what you were saying a little bit, which is these lesions that we had pointed out earlier, they're observable in a lot of different conditions, which I have a table with some positive factors. They're typically reversible. They're considered secondary to a pro-inflammatory environment, so associated with something else. And they should not be used as a full diagnosis, just kind of something else must be going on, a clue that there's some derangement occurring. This slide I can kind of breeze through, but it's just information about speculation on how it could develop. So there may be some cytokine and extracellular glutamate cascade related to some underlying inflammation, and it leads to dysfunction of neurons and microglia, and that can cause cytotoxic edema and then allow visualization. If an MRI is done, you may see some signal change on T2-weighted images and diffusion. And then over on this side, there are some different associated clocks, so just more information about that. And this slide, so a lot of the time when we were working on this case, there was, because of the radiology read on some of the linear enhancement, that was the pattern that was seen. We did, talk about GFAP quite a bit, but it turns out that he never came back with a positive antibody, and the evidence was kind of on the low end for this being GFAP. But providing some information on it, it's often a steroid responsive process and tends to be monophasic, and typically presents with signs and symptoms of meningoencephalomyelitis, which on the right-hand side is demonstrating some associated symptoms there. And typically GFAP IgG would be detected in the CSF. Sometimes it's associated with a neoplasm, more commonly a teratoma ovary, and sometimes neoplasms can express GFAP. So imaging, and this is probably better representative imaging. So 50% of patients have abnormalities on MRI imaging. There's a characteristic linear radial perivascular pattern of enhancement emanating from GFAP-enriched perilateral ventricular regions. Other patterns of enhancement can be leptomeningeal, punctate, serpentine, or ependymal. And also, there can be longitudinally extensive T2 change as well, but it tends to be a little more hazy and subtle than reported in NMO and MOG-associated disease. But the haziness could also be related to patient motion in this case, or just MRI. And then some other findings that are seen, CSF is often very inflammatory. Most would have a lymphocyte predominant elevation in white cells, a lot of elevated protein, variable in oligoclonal band, unique oligoclonal bands in the CSF. And sometimes EEG may have nonspecific change, probably due to encephalopathy that can occur. And then lastly, GFAP itself is a main intermediate filament protein in mature astrocytes and a component of the cytoskeleton involved in astrocyte regeneration, synaptic plasticity, and reactive gliosis. So there's interest in the antigen location of GFAP, and so the GFAP-specific cytotoxic T cells are central to the immune response. It remains unclear if infection is the trigger for GFAP autoimmunity in humans, and so this is kind of just to learn about GFAP itself. Some people think that it's a secondary phenomenon. So I'll stop there since we're pretty kind of low.
No, that's fantastic, Victoria. I think, in MOGAD cases, right, there's a higher percentage of a preceding illness that unmask potentially some children, especially with MOGAD. So I think there's definitely a lot more to learn with these autoimmune conditions. And just to be respectful of time, I think we have about 10 minutes left. And so, Dr. Froman, I know you wanted to talk about your case real quick.
Or just to show the figures.
Yep, show the figures. And then please, we're very excited to hear from you and Teresa about these awards. And I'll leave it at that so you can take us through the excitement.
Yeah. Scott, just before we turn it over to Elliot, I think Raina's been trying to say something for a few minutes. Raina, did you have a final comment before we turn it over to Elliot?
Yeah, I would not dismiss neurocercoidosis at all, despite the fact that it doesn't have all the elements. Where I trained at Wayne with Dr. Lisak and Dr. Lewis, we always used to walk out from Grand Round and say, you don't leave this room before saying neurocercoidosis as a differential diagnosis. And in the 20th century, Sir William Osler said one day, those who know syphilis know medicine. I would say in the 21st century, those who know sarcoidosis know medicine. So that's something to be kept in the back of the mind.
Victoria, could you do us all a favor? Can you go back and see if anybody has ever in this gentleman's history tested for EBV in the CSF? Now, the antibody by this point may now look like previous EBV. Acutely, you might have seen a different pattern, but that would be interesting just because, again, in fact, Clifford is the one who ran the PCR. He's a co-author with Alex and I on the paper. And they can do just about anything. And, you know, they can be post-infectious or infectious. And Don Gilden thought they were all infectious, didn't think the post-infectious EBV was real. But I mean, I think that would, just out of curiosity, because if that's true, it'd probably be monophasic, which would be great for this kid.
Okay.
Great point. Anyway, this is the image of this girl who ended up not having a biopsy or an excision of that splenial lesion you see on the left. And Hope will have this paper linked to this presentation, so anybody who wants to pull it down, it's an interesting story about this kaleidoscopic illusion, and then disclosure by the mom of the older brother having a similar condition. So this is just an example of that. Metabolic. And then Hope, I think you have the announcements. I just wanted to briefly inform the fellows. This has been a great first month, great discussion. The fellows didn't know anything about this, but Tree and I were the co-chairs before Jen and Scott for 3 years, from 17 till 20, and still serve as the co-editors-in-chief of our section in neurology N2 called From the National MS Society Case Conference Proceedings. And we decided, we were so excited about this program that Tree and I have started 2 awards from our foundation. One is the Education Award. So the fellows should keep in mind, this is going to be based on fellow participation, attendance at the webinars, discussion. And in case you think we're kidding, here are the grid sheets that my wife and I have been making notes about all night. So Amy, you, Hamza, we know who you are.
I have mine too, Al.
We know who you are. And this is an award that we really would like to use to catalyze the discussion. I know that Jen and Scott have felt very strongly about sequencing the discussion to go to the fellows first, getting them involved. You guys are a year away from being attendings and in some cases being invited to serve on this faculty. So we think this is a very apt thing to do and really want to encourage it. And we're going to try to make it as objective as possible. Show up to the webinars and, you know, contribute to discussion, and all comments are welcome. The second award is the Academic Excellence Award. So for those fellows who present what the faculty, the inner circle faculty, believe to be the best presentation, get invited to translate that webinar into peer-reviewed published papers in our section From the National MS Society Case Conference Proceedings in the journal, the main journal of our field, Neurology N2, Neuroimmunology and Neuroinflammation, and a section that was created by Tree and I and Kathy Costello and Scott Zanville and approved by the editor-in-chief, Joseph Dalmu, and Bob Gross at the American Academy of Neurology. So we've had 7 submitted thus far. All 7 have been published, and they're unique. We have an amazing medical illustrator for cases where an illustration serves a purpose. They are absolutely gorgeous and extraordinary. So these are the 2 awards. One is for participation as the Education Award, and the second one is Frohman Foundation National MS Society Academic Excellence Award. And we're thrilled to initiate this, and hopefully we'll expand it over the years to come. And I hope the fellows will be excited about this. And again, not competitive, but just excited, exuberant is what we hope for. Any of the MS Society supported fellows are eligible for these awards. So I think I'll just finish with that. Any other comments?
I'll just say thank you, Tree and Elliot.
Exuberant. I think that's
Our pleasure.
Well, and thanks to Jen and Scott, they have markedly improved this program. The hierarchical structure of having the fellows has really transformed the program. It's far superior, and we're just so proud to be part of it.
And I'm still relatively new to these interactions, but this is only my second call, but I'm blown away by the faculty that's involved and all of the fellows as well. And I think this just adds to this program. So thank you so much, Elliot and Tree.
Yeah, very collegial. I want to say one thing in support of what Rana said earlier. One final thing. Years ago, Rana, we did a study, knowing that supratentorial, flare, infratentorial, T2, other sequences. We did a study on 58 consecutive patients with MS who had internuclear ophthalmoparesis. All 58 of those patients had lesions in the region of either the dorsal medial pontine tegmentum or the midbrain tegmentum, 100% by proton density, 88% by T2, only 67% by flare, published in Neurology. So your point about infratentorial signal characteristics with proton density, I felt was very conspicuous tonight. I had to offer that up. It was published a long time ago, but Hope, I'll send you that paper as well to attach. The lesions had all different kinds of configurations, but all 58 had demonstrable lesions, 3 millimeter cuts on the axial. All of them could be identified on proton density.
And in fact, Elliot, in some of the studies as flare came in, for some studies and also for some trials, they've kept they've eliminated the T2 sometimes, but they've kept the proton just so we can get a better look at the stem.
Great point.
Elliot, Scott here. Just want to say kudos to you and Tree, as everybody has said, and N2 is excited, or I should say I am, to continue to publish these case reports. Just a reminder, we have to keep some of those deadlines in mind.
We have one under process right now from our fellow at Hopkins. Yep. And another one. So, yep.
And another one at USC
yep.
as well. That was presented at the end of last year. That's very close now. So all good things.
Right.
And thanks to you too, Scott. Thanks, Scott. And thanks again to Elliot and Teresa. It's amazing what all of you are doing with the articles and with these new Atlas Awards. And Victoria, fantastic presentation.
Great.
I think all of us agree this was a great starting case.
Really was.
Scott,
and thank you, Hope.
Yeah.
Thank you, Hope, for stepping in.
Hope is awesome.
Hope is on the way. Hope is here.
Hope is here. Yeah, thanks everyone for attending tonight. I will post this recording online with the papers that Elliot mentioned within the next couple of days, so that will be there. I plan on sending a follow-up email to everyone too, just letting you know about some National MS Society resources, and you will be hearing from me throughout the year with some information, papers, other opportunities for continuing education, things like that. But yeah, tonight has been phenomenal. Great start, everybody.
Yeah.
Thanks, Hope. Everybody have a good night.
Thanks, everyone.
Thank you.
Night.
Good night.
Yeah.
Jen, by the way, once again, that was one of the best talks I've ever heard. Jen gave a great talk from a London meeting that nobody except for Jeff Bennett from this side of the pond got to. In fact, people from Italy and I guess France didn't even bother to go because of the thing. But Jeff Bennett went. But Emmanuel, Jen, myself, John Corboy, and who else? We all stayed home. Jen did a great talk on aging and MS and senescence.